With this lecture, we're going to look at the diseases of the endocrine and nervous system. We will first look at the diseases of the endocrine system by going over the anatomy and structure and some of the main structures of the endocrine system and how they work, and then as well as the pathology that is common among a lot of the patients that we will see. Now, some of the anatomy of the endocrine system. You can see here that there's various regions throughout the body that have endocrine function. You have here just above the kidneys, you have what they call the adrenal gland, that the pancreas, the kidney itself, adipose tissue or fat tissue can also function, also has some function as an endocrine gland. You see here the gonads or testes. But if you're looking at endocrine function, you're really going to start with the hypothalamus as being one of, if not the main endocrine gland, or one of the main endocrine glands. The hypothalamus releases hormones, a set of hormones called releasing hormones. And what they do is that when they receive feedback in the body, they release a releasing hormone, which tells the pituitary gland to release certain hormones. And then when the pituitary gland comes into contact with that hormone, it then provides what they call a stimulating hormone, and that goes into the systemic circulation to bring about whatever reaction that we are trying to carry out. You see here in the anterior portion of the neck, you have the thyroid gland. And then on this view, you have the parathyroid gland. You see that what the parathyroid gland is compared to the thyroid gland is a bigger gland that sits on the anterior portion of the neck, just anterior to the trachea. And the parathyroid gland are these four, if you kind of zoom in here, there's these four tiny, almost dots along the edges of the thyroid gland. That's the parathyroid gland. All of these are going to have their own function and role, and we will discuss that as we come across it. So kind of going over again the endocrine system and the glands, which include the hypothalamus. Remember the hypothalamus being probably the main one, and the pituitary gland, which sits just beneath it. You have the pineal gland, and what's helpful with this is, as you're going over this list, is get an idea of where these are in the body. So use this slide to keep track of where you find these. You have the thymus, which sits just above the heart. You have the thyroid, which is in the anterior portion of the neck. Parathyroids, adrenals, which are glands which sits on the superior aspect of the kidneys. Pancreatic islets, ovaries, and testes. Each gland is unique and delivers secretions into the bloodstream. Negative feedback system controls the amount of hormones released. And what a negative feedback system is if the body senses that there is too low of a certain amount of something, it will then start creating hormones to raise it back up or get it to a normal homeostasis set level. When it then reaches a certain amount, the same sensors will then sense that, hey, we're back to normal, or we have enough of this hormone, so then it stops the signal, and that's referred to as a negative feedback. So a simple example of this would be is if let's say we're outside and it's a really hot day and we've been running, we've been exercising. Well, our body temperature is going to be really warm. So there are things that need to happen in order for us to cool ourselves down. So one of the things we'll do, obviously, we'll have a desire for thirst, so we can drink water to cool us down. We'll also sweat, which then allows us to evaporate heat from the surface of our skin. Our blood vessels will dilate. This is a negative feedback. So our body received the response that, hey, we're really warm. So the negative feedback on that is to try to cool the body down. If it was a positive feedback, if it was the opposite of this, anytime our body temperature started to raise, our body would try to raise it even more. Those are very rare, very common. In that example, if your body was already really warm and then it started heating up more, that would be very dangerous. Typically, you only see positive feedback. You see positive feedback examples with childbirth, when there are increased contractions of the uterus. You'll want to increase the contractions so the child can be born, and also during breastfeeding. And these are a few of the examples of positive feedback, but most of the controls, particularly with the endocrine, are going to be negative feedback. So once you have gotten to a certain level with these hormones and you've reached the level that you need, you're then going to stop that. There's going to be a cessation of the hormone, and then cessation of the effect. So if we go down to this slide, looking at the hypothalamus, some of the hormones, and trying to keep track of these, this is going to take some time to kind of work through these. But the hypothalamus, what it actually produces as far as regulatory hormones, or hormones that are created by the hypothalamus that have an effect directly on the system without being a releasing hormone, or what they have listed here, a regulatory hormone, is this ADH and OXT. And if you see, we don't have it listed here, what ADH is what they call an anti-diuretic hormone. So if your body, if the hypothalamus gets feedback that you have too low of water in your system, it will release this hormone to tell your kidneys, hey, hold on to water, don't release it. Oxytocin is important for those other two that those two examples of positive feedback I had listed. So oxytocin is important for stimulating the uterus, and there are some other effects in the body, but that's one of the main ones, stimulating the uterus during labor. So important with positive feedback. Now, most of the hormones that it releases, so those are the two that it actually produces and that its effects go directly to the body. What it usually does, though, is releases regulatory hormones or releasing hormones that tells the pituitary gland to then release their hormones. So you can see here, and we're not going to go over each one of them right now, but you can see the list. So the hypothalamus gets some sort of feedback. It releases a regulatory hormone, tells the anterior lobe, and that's important to remember, it's going to be the anterior lobe that's going to receive that feedback, and it's going to release then one of these stimulating hormones. And then you can see the list listed here. What is released in the posterior lobe are the two hormones that the hypothalamus creates, that oxytocin and antidiuretic hormone. The pineal gland creates and releases melatonin. You may have heard of melatonin. Some of you may take melatonin to help you sleep. Important for that circadian rhythm and regulation of our sleep cycle. Down here in the cervical region, so remember the parathyroid glands are these glands that are sitting they're sitting on top of along the posterior aspect, but on top of the thyroid gland. They release a hormone, which is pretty simple to remember. It doesn't really tell you what it does, but it's just referred to as the parathyroid hormone. Okay, and then if you come down here, and we're not gonna go through this list right now, but you can see these are, as we go through them more and as we learn about the pathology, you'll start and if you refer back to this particular slide, it can be very helpful with knowing, hey, this is what is being released, and when we start learning why they're released. So you have the thyroid gland. Important. These hormones in particular particularly these first two are important for metabolism. So you may have known someone who says they have a hyperthyroidism, or they have a hypothyroid, or they have a low functioning thyroid. Maybe they have difficulty losing weight. That they could have a decreased function of that. You have the adrenal gland, which sits here on the, as I said, on the superior aspect of the kidney. Different portions of the adrenal gland will release different hormones. The pancreas, its two main ones are insulin and glucagon. Both of those are involved with blood sugar. So insulin, probably most of us are familiar with that, and that insulin responds to when our blood sugar is too high or is higher. Like when we eat a meal, our pancreas will release insulin to try to get it back down. And then you can see here the heart, thymus, the adipose tissue, digestive tract, the kidneys, gonads, testes in males, and ovaries in females all release different hormones throughout the body, which function and then make up this endocrine system. And they interact and some play off one another. Many of these have then opposite effects. So a quick example would be insulin responding when you have high blood sugar. So you release insulin to try to lower it. Glucagon does just the opposite. If your blood sugar is low, like you've been fasting, then your pancreas releases glucagon to release stored glycogen or sugar in our liver and some in our muscles to release into the bloodstream to try to raise the blood sugar. Just another comprehensive list. Could be a little overwhelming looking at this right now, so I would advise not looking at it right now. It also goes into the classes of the hormones, but for right now, don't worry too much about this slide. Okay, so the pituitary gland, or what they call the hypophysis or hypophysis, it's the same thing. It's just a different word meaning pituitary gland. So if you did come across this term, you will see this term often in certain literature or in textbooks. Just know that it's referring to the pituitary gland. This is it's not a common name you're typically going to come across in a clinical setting, but it does come up. You can see here that the pituitary gland sits on the base of the brain. If it actually sits in this section within the sphenoid bone, if you remember back to our orthopedic slides, it's okay if you don't, but on our orthopedic slides, it sits inside the sphenoid bone in a specific part referred to the sella turcica. That's just information. You don't need that information, but just to give you an idea of where it's located. Here is an actual cut section of it. So you can see the anterior pituitary gland in sort of this darker red color, and then the posterior pituitary gland being a lighter color. And this is a diagram here kind of showing the different tracks. Don't worry about the naming of this. Just know that this anterior portion here, if we remember, just above it, you have the hypothalamus, and the hypothalamus is going to release regulatory hormones or releasing hormones, which are going to act on the anterior portion, the anterior lobe, and cause these hormones to release into the bloodstream. The posterior lobe, its job is to release the two hormones that the hypothalamus creates, which is oxytocin and antidiuretic hormone. So if we look at, you can see here how expansive this pituitary gland is, and that hypothalamus and pituitary gland system is, and all of the effects that they end up having on the entire body. So this one this hormone right here that's released, this GH, that's growth hormone, obviously important for our growth and our development as we age and as we go through different areas of growth in our life. During puberty, this is going to be very active and very high, and will decrease as we age. You have this TSH, which is a thyroid stimulating hormone. It's going, after it's released, the releasing hormones released from the hypothalamus. It will tell the anterior lobe to release thyroid stimulating hormone, which will then go and stimulate the thyroid to do what it needs to do. And then so on. You can see that you have this the effects on the adrenal gland, effect on the testes, ovaries, the breast tissue, uterine contraction, lactation, and then kidney and water absorption. So very expansive and very important. So if there's, I've actually worked with a patient who had a tumor on her pituitary gland. So it had, I believe most of her pituitary gland had to be removed. So you can think about all the different issues and problems, one that she was probably seeing because of the tumor, and then that she would then have because she didn't have that regulatory function anymore that the pituitary gland had over the endocrine system. Okay, so hyperpituitarism. So if you had an increase or excessive pituitary gland function, you can see here one of the problems you'll see is that what you're going to have an increase is an increase in all of these hormones. The one that you will see a huge effect on is this growth hormone, and you can see the height of this woman here. Looks like she's probably well over 7 feet tall. So it'll be an increase in the activity of the pituitary gland. An oversecretion affects growth hormone, leading to excessive growth of bones and tissues. If it occurs before puberty, gigantism occurs. And so you can see in her case that the hyperpituitarism happened before puberty. So the reason why she ended up becoming so tall. The reason why that is because when we're growing during puberty and we're a child, the end plates, the growth end plates in our femur and in the rest of our bones, really all of our long bones, they're not set. So they're constantly growing in length. So if you have this, they're not set, they're not calcified, you can just keep growing this if it keeps receiving feedback that, hey, there's more and more growth hormone, let's just keep growing. And so that is that gigantism, which then occurs because of this. There's a different term used if this occurs after puberty. There's still growth, but the growth is more almost in width. You'll typically see it in structures of their face. That if it occurs after puberty has ended. And so, right here, you have the occurs during adulthood. This condition is acromegaly occurs. So it affects small bones of the hands, feet, and face by enlarging them. So you can see the change in this man as he had this condition. He was an adult, and you can see because it has a normal bone structure. But as this disease progressed, he would still have continuing growth of the bone in his cheeks and forehead and in his chin and mandible. All these bones continue to enlarge to where you get here later in life, and the progression of this disorder, he's almost completely unrecognizable compared to where he was. This condition is acromegaly. If it's before puberty, it's gigantism. Hypopituitarism. which is an abnormal decrease in activity of the pituitary gland. So you think of, again, growth hormone. Symptoms being dwarfism, so a lack of growth, abnormality of sex characteristics. If we come back here to slide 10, this FSH and LH, these are both important for this luteinizing hormone and follicle stimulating hormone, both important for the development of sex characteristics as well as the development of sperm and ovum. Amenorrhea and infertility in adult females, and lower testosterone level and decreased libido, loss of facial and body hair in adult males. So you see a lot of these different sexual characteristics, which would occur because of testosterone or because of proper levels of progesterone and estrogen in females would impact this disorder. Diagnosis of pituitary function by blood test, and then treatment would be hormone replacement, monitoring, and adjustment, depending on the levels that were given. Next, you have what they call diabetes insipidus. So if we go back real quick, here you have these hormones. If we remember, this antidiuretic hormone is going to function on the kidneys and this water absorption. Now, what this diabetes insipidus is different than typically what we think of as diabetes, which is diabetes mellitus. So that when you're talking about diabetes mellitus, you're talking about types 1 and type 2. Diabetes insipidus is a different disorder. It's caused by a defect in the pituitary gland or defect in the kidney tubules. Both defects result in a decrease of that antidiuretic hormone. Sometimes also, this hormone is also referred to as vasopressin. Symptoms, it's excessive polyuria or excessive urination, urinating 2 to 15 gallons of urine in 24 hours. So that is even 2 gallons would be a lot, would be a huge amount. So up to 15 gallons, that's incredible. So the renal threshold plasma concentration at which if we're looking at these carrier proteins, and basically there's so much urine that is being lost that you're not then recovering glucose. So it ends up getting out into the nephron, and then there's so much, the secretion is happening so fast that you lose glucose through the urine, and you're not recovering it. So that ends up causing this diabetes insipidus. So some of these symptoms you'll see, along with that, of course, the excessive polyuria, polydipsia, hypotension, dizziness, constipation. Diagnosis, urinalysis, so you look at the content of the urine, and also water restriction test. Treatment would be administration of vasopressin, which you could do it medicinally, and then medications that lower urine output. So this is not typically a chronic condition. It can be treated through medication effectively, but it has a distinct etiology than from diabetes mellitus, which is your body's inability to regulate the sugar in it properly. Okay, now we're going to look at thyroid disorders. So endocrine glands that can be physically examined, the thyroid and testes. So the thyroid sitting in the anterior portion of the neck, if you had some sort of dysfunction of this gland, or if it was excessively large, it could be easily palpated. And then obviously the testes being outside of the body would be easily examined. Diagnostic tests include urine and blood testing for hormones, CT scan and MRI for tumors or alteration in organ size. So if we look at follicles, so we're looking at these We're looking at these, so these follicles are portions within the thyroid itself, which are then going to create these this hormone, these T4 and T3. If we go back to the hypothalamus, let's look at it up here. The thyrotropin releasing hormone is going to release, or this regulatory hormone is going to release from the hypothalamus and go to the anterior pituitary gland and stimulate it to release a stimulating hormone. This thyroid stimulating hormone is then going to go down to the thyroid gland, and thyroid hormones are important for metabolism. So the rate of our metabolism, how much or how little we burn calories, and we put into growth and development and different functions in our body. Now, this T3 and T4, the difference is that thyroxine, or T4, is more of the inactive form of T3. So it gets released into the bloodstream primarily as T4. And if you see this ratio down here, 14:1 to 20:1, T4 to T3. So for every one T3 hormone, there will be anywhere from 14 to 20 of the T4s. Now, when you need a reaction or function to come along, it will then convert T4 to the active T3 as needed. This is probably more information than probably you need to know, but iodine is important for the formation of these hormones. And iodine being, you probably have seen it on like labels for salt. Typically not something that we see a lot of times in the United States, but in a lot of third world countries, you may see people who have what they call a goiter, which is an enlarged thyroid because of this lack of iodine in their dietary supply. And so these cells start to swell and to expand, and could then possibly create a dangerous situation with their breathing, and obviously is very, very noticeable when someone has a goiter. So this is just looking at some of the ways that we have the production of this hormone that is called calcitonin. Now, calcitonin is a hormone created by the thyroid gland, which allows calcium to go in to bones. So if you have a high blood calcium level or extra, let's say you drink some milk or something, if you want to put calcium in, so calcitonin into bone, you will then release this calcitonin. And so these parafollicular cells in the thyroid glands are the actual cells inside the thyroid gland which produce calcitonin. So let's say someone had a disorder in which they weren't producing calcitonin. Well, you got to then think of what the adverse effects of that would be. So they would have difficulty putting calcium into their bone and absorbing it. And so obviously you would have weakened bones, very brittle, and would easily fracture. Okay, so hyperthyroidism. This is thyroid gland secretes excessive thyroxine. Remember, that's that T4. Causes could be a tumor of the thyroid gland, hereditary, so it means passed on from generation to generation, excessive intake of iodine. Typically, if you saw that, that would be not the fact that we have our salt that is fortified with iodine. So that being one of the main dietary intakes of it. So maybe someone's eating too much salt. Excessive thyroid hormone medication or Graves' disease is the most common cause. Graves' disease being a thyroid disorder of having this extra thyroid hormone. This Graves' disease is an autoimmune condition. Antibodies stimulate the thyroid gland to produce hormone. So symptoms would be a goiter. As I was mentioning earlier, that would be that enlarged bulge on the front of their neck, tachycardia or fast heart rate, nervousness, hyperactivity, weakness, mostly because the internal environment is so ramped up that it leads to a weakness of their body in general, excessive excitability, and tremendous appetite with weight loss. So they may be very hungry, and may eat quite a bit, but they'll still lose weight. Other symptoms being diarrhea, high heat production, moist skin, extreme thirst, and exophthalmos. What this is, you may have seen someone like this. This is a bulging eyes. So if you look this up, it's almost like people who have this Graves' disease and have this exophthalmos. It sort of looks like a cartoon when you'd see like their eyes pop out, or kind of this bulging appearance to their eyes. Very distinct look. And if you saw someone who had this exophthalmos, most likely it's due to this hyperthyroidism. Treatment would be medication, radiation, and surgery. Surgery could be to try to remove the thyroid gland, or it could be specific to one of the conditions or one of the symptoms. A simple goiter, which is that enlargement of the thyroid. Remember, the cause could be hereditary, eating goitrotropic, goitrotrogenic foods, and iodine deficiency. Symptoms: thyroid enlargement, may be asymptomatic until the gland is quite large. So it could be almost kind of like a small lump, and they may not really know what it is, or just think, oh, I just have kind of a lump there in my throat. And then could be asymptomatic, but if it got large enough, then you would see significant impairments. Treatment would be potassium iodide followed by iodine in diet, and surgery to decrease dysphagia and dyspnea. Hypothyroidism. So now looking at a decrease in the thyroxine in the blood produced by the thyroid gland. So remember, in this case, you would still have, from the hypothalamus, you would still have the thyrotropin releasing hormone from the hypothalamus, and then you would still have this thyroid stimulating hormone from the pituitary gland being produced, but there's potentially a dysfunction with the thyroid gland itself, where it's not either receiving the message, or maybe somewhere along the line it is not being produced correctly with the releasing or the stimulating. And remember that it has this negative feedback effect. So as you, with these thyroid hormones, you've reached a certain level, it should then tell the hypothalamus to stop releasing the releasing hormone. Hypothyroidism in adult is referred to as myxedemia, and congenital hypothyroidism is cretinism. So in adulthood, myxedemia, and then congenital or childhood cretinism. Symptoms include fatigue, sensitivity to cold temperatures, thin nails and brittle hair, excessive weight gain, which is one of the distinct features of it, compared to hyperthyroidism. Diagnosis by blood hormone level, and then treatment would be hormone replacement. And this is a nice slide sort of showing the differences in the signs, symptoms, and issues that you will see. So you see hypothyroidism, typically would have high cholesterol levels, easily gain weight, decreased fertility and reflexes, sluggishness, feeling cold, constipation, lethargy, fatigue, and then some similar ones with you also will see some fatigue and weakness, but you also see anxiety, tremor, tachycardia, feeling warm, loss of weight, that exophthalmos we were talking about, atrial fibrillation, and decreased fertility. You see they both have decreased fertility, but the hyperthyroidism, basically you're going to increase a lot of these things, while hypo, you're going to decrease. Now we're going to go to parathyroid diseases. And remember, these are on the posterior aspect of the thyroid gland. There are these four little, almost like skittle shaped embedded glands on the posterior aspect of the thyroid gland. These are the parathyroid gland, which produces parathyroid hormone. Overproduction. So if we're looking at hyperparathyroidism, it's an overproduction of these parathormones or parathyroid hormones by one or more of the four parathyroid glands. Causes could be hypercalcemia, so it's high blood calcium levels, leading to kidney stones, bone weakness, and hyperactivity of the heart. Anytime you have a fluctuation in calcium in your body, calcium is very important for muscle contraction, both for skeletal muscle and for heart muscle. So if you had too high of calcium levels or too low of calcium levels, it'd be dangerous for someone's heart, not just for bone. Obviously, we kind of think about the bone when it refers to calcium levels, but you also have to think about the muscle. Diagnosis will be by blood tests, treatment directed at the cause. Prognosis is good with treatment. Okay, now then we have hypoparathyroidism. In this case, we're going to have a decrease in that parathormone, leading to low blood calcium. So what parathyroid, if we go back, the thyroid gland releases calcitonin. So it releases calcitonin when your blood has more calcium in it than it needs. And so what it does is it tells the calcium to go into your bones and into your muscles. Parathyroid hormone, its job is to cause the body to increase the blood calcium level. So how it does that is that it breaks down some of the calcium in your bones to raise it back up. So if you didn't have parathyroid hormone, you would have a decreased ability to increase the calcium level in your blood, leading to this low blood calcium level. What that would cause is irritability of the muscles, causing tetany. Tetany would be like a locking up of your muscles, like this, it'd be stuck in contraction. Calcium is extremely important you may not remember, but in the sliding filament theory, how our muscles contract and how they slide against one another. Calcium is important basically for the ability for our muscles to contract in the first place. And so throwing that calcium level off will then lead to this condition. Uncontrolled contraction of muscles in face and hands is common. Diagnosis would be blood tests, Chopsek's sign, Trousseau sign. You can kind of look those up and see what that's referring to. Treatment would be vitamin D and calcium. Okay, now looking at the adrenal glands or adrenal gland diseases. The adrenal glands are the structures that sit on the superior aspects of the kidney. They're also referred to as suprarenals. Supra just meaning superior, renal meaning kidney, so sitting on the superior aspect of the kidney. there's two distinct parts of the gland. And here you have a section of it cut out where you're seeing the inner medulla and the outer cortex. And they have different functions and different things that they release. The inner, the medulla, releases epinephrine and norepinephrine. These are what you typically refer to as adrenaline. So you may be, I remember one time years ago, when I was a teenager, I was laying on the floor and I was playing video games. And I was pretty calm. Like, I wasn't that into the video game. I was just kind of playing it. And I remember I felt something crawling on my left arm. I just felt movement. And I looked over and there was a spider crawling up my arm. Well, my fight or flight hormones kicked in pretty fast. And so it causes these instant increases in blood flow to your muscles and movement and dilation of your pupils. Anything that would allow you to get away from a scary situation, or if you were needed to run or whatever. I remember with that story, actually, I stood up and tried to find it to kill it, and I couldn't find it. And I looked for it for a few minutes and couldn't find it anywhere. So I guess I could have just sat on the couch, but I decided to lay back down. And about 10 or 15 minutes later, I felt it crawling up my other arm. And so maybe he was trying to be friends with me, but it wasn't a good outcome. I was able to kill him that time. But this is typically what we're thinking of when you think of adrenaline. You're thinking of these hormones, this epinephrine or norepinephrine, and it's released from this inner medulla. The outer cortex portion is controlled by the ACTH. This is a hormone released by your pituitary gland that that is controlled by that hormone. So adrenal glands secrete what they call mineralocorticoids, glucocorticoids, and sex hormones. So the mineralocorticoids, one of them, or the one we're thinking about, is aldosterone. Aldosterone, when your kidneys, or when these adrenal glands, release aldosterone. Aldosterone is used when we're very similar to ADH, in that you're antidiuretic hormone, in that you're trying to stop the kidneys from excreting more urine. You're trying to retain as much water as possible. So you can almost group this aldosterone in its similar function to antidiuretic hormone. And you see that it's showing the sodium potassium regulation through the kidneys. Well, anywhere that sodium goes, so if you're going to retain some sodium, water is going to come with it. If you get rid of sodium, water is going to go with it. So if you're retaining sodium or potassium, water is going to go with it. Then you have a group called the glucocorticoids. This is cortisol and hydrocortisone. These are sometimes referred to as stress hormones. And then the sex hormones, or are responsible for sex characteristics. You have androgens, which are responsible for male characteristics, and then estrogens, which are for female characteristics. Okay, next you have cortisone. This is a glucocorticoid used to treat inflammatory disease. Should be used short-term only. So you may have heard of someone getting a cortisone shot when they've maybe bad knees or a bad hip, getting a cortisone shot. It's supposed to just be used short-term. It is very effective for treating pain, but some of the side effects of it are hypertension, ulcers in the stomach, a moon face, which is sort of kind of like a round face in appearance, drowsiness, may mask symptoms of infection. So if there's infection in the joint itself, and actually one of the ones not listed here is actually, it leads to more brittle bones. So it's a lot easier for someone to break their bone. So if I know I had a patient who he had a fractured fibula and he had a bad knee on the same side and he wanted to get a shot in the knee. We had to explain to him that he can't get, at that time, couldn't get a cortisone shot in his knee because it would delay the healing of the fibula. And so it could delay it altogether or delay it by several weeks or months. Okay, some of the conditions you also have, you have this hyperadrenalism, so over secretion of the adrenal cortex hormones. Now remember, those adrenal cortex hormones is ACTH, or is controlled by the ACTH. Conn's syndrome, overproduction of mineral corticoid, aldosterone, electrolyte imbalance, alkalosis, hypertension, usually due to cortex tumor. So if you had in this case, if you had this Conn syndrome, you had too much aldosterone, you're retaining too much sodium, potassium, and ultimately water, and why you would see hypertension, why you would see this electrolyte imbalance. Cushing's syndrome is a fairly common syndrome. It's overproduction of glucocorticoid cortisol, caused by a tumor on the pituitary or adrenal cortex. Some of these signs, or some of the things that you'll see with people who have that, is a round face, kind of hunched or hump on their back, thin limbs, hypertension, and there's a few other signs as well. So I guess hyperadrenalism, oversecretion of adrenal cortex hormones, androgenital syndrome, which is overproduction of sex hormones, hereditary, and it's usually in early puberty, either feminization or masculinization. So you either have excessive of one of these things. Hypoadrenalism, or Addison's disease, is a low secretion of hormones by the adrenal cortex. So you kind of see a common theme with a lot of these glands is that either there's a normal functioning level, or you're going to have excessive. And with following endocrine system, it's like having an understanding about, hey, what the normal is, what should this be doing, and then then if it's hyper, if it's too much, hey, you're doing too much of this thing, and there's some problems with it. And if there's hypo, some of the signs and symptoms that are associated with that. But it has to do really with the levels of hormones that are being secreted. So furthering on with Addison's disease, uncommon, it's autoimmune, usually caused by a tumor of the pituitary, could be caused also by tuberculosis or the use of steroids. Approximately 90% of the cortex must be non-functional to be symptomatic. So you can see that almost the entire cortex. So let's say you'd have to kind of get to the point where all of this was dysfunctional. Maybe just this bottom portion was functional still before you would start actually seeing symptoms. You'll see hypoglycemia, electrolyte imbalance, hyperpigmentation. So maybe seeing patches of increased melanin on their face or in other parts of their body. Okay, now we're going to the pancreas. The pancreas is both an exocrine and an endocrine gland. The difference is that an exocrine gland excretes its substance or hormone on the outside surface. It's sort of weird to think about it this way, but on the outside surface of the body. And the endocrine is a gland that secretes its substance into the bloodstream. So endocrine is always going to be bloodstream. The reason why this is that the pancreas secretes its pancreatic juice, it secretes it into the small intestine. Now, when you're inside the lumen of the small intestine, actually anywhere from the mouth, on the lumen of the esophagus, down through the stomach, intestine, all the way out through the end, that whole range is actually outside of your body. You don't get inside of the body until it's absorbed at some point along the intestinal tract. So, because you are releasing um, pancreatic juice outside or into the small intestine, it's also referred to as an exocrine gland. They have these islets of Langerhans secrete this insulin and glucagon, and I've already kind of talked about what each one of those do. Insulin lowers blood sugar, glucagon increases blood sugar. So they have the opposite effects depending on where the body is. And so any dysfunction from that, or if you had too much insulin or too little glucagon or whatever, would lead to whatever um, being impacted by whatever that hormone was supposed to do. So let's say you had too little glucagon, or you had non-functioning glucagon. Well, um, you would then be fasting, and you wouldn't have any way to increase your blood sugar other than eating. But let's say you were fasting or weren't able to get to a meal. Well, if you weren't able to tell this hormone to go do what it needed to do, you couldn't raise your blood sugar. And so leading to hypoglycemia and potentially to something really bad. Sugar and glucose, primary source of energy for all tissue and cells. So that's what these are going to function and work on and respond to. So pancreas, both, again, remember, both exocrine and endocrine glands. The insulin and glucagon being released into the blood and functioning in the blood these are going to be the endocrine gland functions. How insulin works, insulin is released by the pancreas when you have extra sugar in your blood, which you don't need. Insulin comes down and attaches to a receptor on our cells. Now, this receptor, almost all the cells in our body has this insulin receptor. So in our muscles, in our fat cells, our heart, stomach, because everything needs sugar as a way of energy. Insulin attaches to this receptor, and the receptor says, okay, insulin's present. That means we need to open up this other channel to let in glucose. And so what happens with, maybe I won't go into that yet because it's possible we're going to go over that in other slides. But think about this. This is kind of the normal functioning of this is that insulin attaches to a receptor, glucose comes in on a different receptor on this GLUT4. You don't need to know what's GLUT4, but glucose then comes into the cell. Diabetes mellitus, commonly known as just diabetes. This is different from that diabetes insipidus, which has to do with excessive antidiuretic hormone and letting basically there's too much, a decrease in the antidiuretic hormone. So there's too much fluid being lost. This is the most common major disease of the endocrine pancreas. Affects carbohydrate and sugar utilization due to lack of insulin. Some of these symptoms are going to be polydipsia, which is excessive drinking because there's going to be a lot of thirst, polyuria or excessive urination, polyphagia, excessive eating, glucosuria, remember that renal threshold, high urine in the sugar. In a normal case, you shouldn't have any shouldn't have any sugar in the urine, but it reaches a threshold in the blood that you're no longer able to return the glucose, so it ends up filtering out in the urine. Hyperglycemia or high blood sugar. Okay, and here you can see kind of a breakdown, some of the risk factors being age, obesity, genetics, sedentary lifestyle, poor diet, or certain races are more predisposed to having diabetes. There are two types of diabetes. Now, there are risk factors for both of them, and there's kind of common terms for each, but neither one of the common terms or thinking about it are necessarily accurate. Okay, so the first one we're going to look at, so there's type 1 and type 2 diabetes mellitus. Type 1 is, many times you will hear this referred to as juvenile onset. It does, and the reason why that is most of the time it's diagnosed in children or people who are before the age of 25, most of the time. What this is that it was previously known as insulin-dependent diabetes mellitus. Requires daily insulin, injections of insulin, thought to be autoimmune disorder. What it is with this is that the pancreas itself doesn't produce insulin effectively, or doesn't produce it at all in more severe cases. So because you're not able to produce insulin, you have no way, if we go back to this chart, there's this receptor right here, or sorry, this insulin here doesn't exist. It doesn't naturally in the body. So there's nothing for this insulin receptor to respond with. And so this GLUT4 transporter doesn't allow glucose into the cell. So if someone with type 1 diabetes eats a meal, let's say they don't produce any insulin, they need to have this insulin injection. Well, let's say they drink a soda, and they're not controlling it well. Well, what will happen is that their blood sugar will start becoming dangerously high. They don't have any way of taking it into their cells because they don't produce this insulin. They then need to inject themselves with insulin. And there needs to be a certain amount of insulin that they give themselves depending on what they eat, so they know, hey, this is how much I should lower my blood sugar. Because if let's say maybe they thought they were going to eat a bigger meal than they were going to, or maybe they took an insulin injection, and then didn't eat for a while, they could actually end up doing the opposite, where they drop their blood sugar really, really low. So with type 1 diabetes, it's more dependent on insulin, and it does commonly obviously affect children, but there are actually people later in life where this can become acquired, and this does happen. And you see here, they don't usually secrete insulin, or they don't secrete enough of it, or they have a pancreas which is just not functioning correctly. Individuals with type 1 diabetes must follow a strict diet, monitor blood levels, administer daily insulin, and exercise and stress can alter insulin needs. We won't really go into it right now, but exercise is actually one way that our body can get blood into our cell, can get blood sugar in our blood into our cells independent of insulin. That's kind of beyond the scope of this class, but let's say they had insulin and ate a meal and then exercised. Potentially they could then lower their blood sugar more than they need to if they were just using the insulin. Okay, now type 2. Typically this one's kind of seen with people who are sedentary or overweight, and those are common risk factors, but that's not always the case. You don't always see somebody who is I know there was a professional football player, Patrick Peterson. He's played for the Arizona Cardinals up until this point. He's played, I think, more than 10 years, or close to 10 years at this point. But he, obviously being a professional athlete, is very in shape, exercised, wasn't sedentary, but he developed type 2 diabetes. What type 2 diabetes is, they have insulin and they produce insulin, but their insulin receptors don't respond to insulin the same way. So for whatever reason, this insulin receptor starts to malfunction. So, formerly known as non-insulin dependent. So in their case, they'll have insulin, it'll kind of go out, but since they're not having these receptors that are functioning properly, it will then cause their blood sugar levels to remain high. And so what has to happen is that their body has to produce even more insulin. And for the receptors that are responding, they're going to like basically be like worked really, really high. They kind of have to. And over time, your cells are going to respond by creating more receptors. And typically why you see people who are obese have it. And so it's kind of like, well, what comes before the other? Are they obese so they have diabetes, or do they have diabetes because they're obese? It could be either. This is the more common form of diabetes, gradual onset, occurring most often in obese females over age 40, but it affects all sorts of different demographics. Now frequently seen in younger obese persons, thought to be caused by wearing out of pancreatic islets of Langerhans due to upregulation, which is just increasing insulin resistance, and usually controlled with diet, exercise, and oral medication. So unlike type 1 diabetes, where you have to have these daily injections, a lot of it can be controlled or improved by diet, exercise. And so they may also require insulin secretion depending on progression of the disease. And usually if they get to this point where they require this much, then it's very poorly controlled. So some complications, both coma and shock are a result of improper insulin administration. A diabetic coma, subsequent to diabetic shock, not enough insulin, too many carbohydrates is what leads to this. So if they gave themselves too much insulin, well, let's say they gave themselves a good amount of insulin, I'm going to eat all this candy. And then let's say they didn't eat any of the candy. Well, the little bit of glucose that they had in their system then gets taken up because of the insulin, and then they go to dangerously low sugar levels in the blood, leading to this diabetic coma. Diabetic shock progresses quite rapidly. Is hypoglycemia, too much insulin, not enough carbohydrates in diet, symptoms being diaphoresis or excessive sweating, lightheadedness, trembling, and a state of confusion followed by the coma. So it's going to be a progression, being someone going into a diabetic shock first, and then that progressing to potentially to a coma. Coma from insulin shock is a medical emergency. Some complications, coma and shock, atherosclerosis, which is plaque formation in your blood vessels, diabetic retinopathy, kidney damage. Diagnosis, usually from history and physical and blood glucose testing. No cure, individual must follow treatment plan for life. Particularly with type 1, they're going to have daily insulin injections or some sort of maybe an insulin pump or something. And then with type 2, depending on the stage and how progressed it is, it could be controlled through their diet and exercise and everything. Okay, then there's one more type of diabetes. This is gestational diabetes. It occurs only during pregnancy, usually discovered with routine urine testing during prenatal visits. Treatment would be diet, exercise, medications, injectable insulin to control the blood glucose. Usually disappears after delivery, often affected later in life by adult onset diabetes. So if someone has gestational diabetes, pretty good chance that they could have then an adult or type 2 diabetes later on. There's no preventative measures, but women who observe a healthy lifestyle and normal weight at conception are at less risk. Hypoglycemia, abnormally low blood sugar, meaning less than 60. Now, this doesn't show it on here, but normal levels for blood sugar are between 70 to 100. It's kind of a normal range. You start getting to what they call pre-diabetes if the level is above 100. If you are below 60 or less than 60, it's referred to as hypoglycemia. Symptoms would be lightheadedness, diaphoresis, trembling. Diagnosis through a blood glucose test. Treatment depending on the cause. Because it could just be through the fasting, so you may just need to eat something. Could be hereditary, adenoma, or GI disorder, potentially. Okay, so next we're going to get into some reproductive gland diseases. So things affecting particularly the testicles and ovaries and uterus, things that are going to affect based off of the hormonal environment that they're in, potential diseases that you will see. So one, you will have hypergonadism, which is increased hormone production before puberty. Diagnosis by blood test for elevated hormones. Treatment will be removal or radiation of tumors to suppress the hormones, and administration of hormones to suppress or counteract the sex hormone. Hypogonadism, decreased hormone production by the age of puberty, diagnosis by blood tests and hormone levels, and then administration of testosterone and estrogen as needed. Okay, some other trauma. Head injury can lead to multiple organ dysfunction. Organ destruction and failure can be life-threatening. And some rare diseases. Most diseases of the endocrine system are relatively uncommon, with the exception of thyroid problems and diabetes, which are very common. Effects of aging: decreased secretions from glands, lessened glucose tolerance, digestive and metabolism problems are common, and then diabetes mellitus is very common in advanced age. So even if someone isn't obese or really had that many issues, it's very likely that if they're a little bit older in their 70s or 80s that they potentially have then developed diabetes. Okay, so that wraps up our endocrine system with diseases. Now we're going to look at the nervous system. So a few of the structures and then diseases that we see that are related to that. So the nervous system, we're looking at the brain, spinal cord, and nerves. The central nervous system, now this is a very good distinction to remember. The central nervous system is going to be the brain and the spinal cord. Any spinal nerve or nerve outside of the spinal cord, is going to be what they call the peripheral nervous system. So central nervous system, brain and spinal cord, peripheral nervous system, and then components of the peripheral nervous system. You have the autonomic nervous system, meaning that it's going to function automatically. And then you'll have cranial nerves, so nerves that come off the bottom or the inferior and anterior aspect of the brainstem, cranial nerves, and then you'll also have these spinal nerves here in green. So you have brain, spinal cord, nerves. Here it's kind of showing the different regions. This is just kind of for your information. You don't really need to know this, but you see in the cervical region, in the cervical spine, you're going to have 8 spinal nerves, and then the rest are going to kind of coincide with the different spinal levels. So thoracic, you'll have 12 pairs, and lumbar, you'll actually have 5 pairs of nerves going out on each side. So you have a lot of spinal nerves going out. You have to control everything, all the muscles, and get sensory information from your organs. And that's all going to branch out here just outside of the vertebral column when it branches off the spinal cord. Common signs and symptoms of dysfunctions: you're going to have headache, nausea, and vomiting, weakness, potentially have mood swings, and fever. Symptoms specific to the CNS: stiffness in neck and back and extremities, inability to move any part of the body. So if you have some dysfunction or you have maybe a pinched nerve somewhere, you're going to have reduced ability to move that part of the body. So if you have a pinched nerve here in your, let's say right here in your axillary region, you're going to have difficulty moving the muscles in your arm. You could see seizures or convulsions, paralysis, inability to speak, visual difficulties, extreme or prolonged drowsiness, stupor, unconsciousness, amnesia, or extreme forgetfulness. So, um, and so I guess in this case, if, with kind of a compressed uh, nerve, this would be a peripheral nerve problem, where if, let's say, this portion of the spinal cord had damage to it, then you could see problems here, an inability to move it or complete paralysis. So some diagnostic tests, you could look at reflexes. So people who have a central nervous system problem, so it's an issue with their brain or spinal cord, with their reflexes, they're going to be hyper reflexive. Meaning that if you did like that patellar reflex with the reflex hammer to the patellar tendon, it would kick out really hard. If they had a peripheral nervous system problem, it would be hyporeflexive. There would either be a very diminished reflex or none at all. So it's one, it's a simple test to do, but let's say you're doing this test on someone and they kick out really hard. Well, there may be an issue with their brain or with their spinal cord. And, compared to if you did this with someone who had a peripheral nerve problem, you may not see any reflex. And so maybe there is a compressed nerve or a damaged nerve or something. And so you can also look at gait and posture. So someone with the spinal cord or any central nervous system problem would have difficulties with gait. You could look at sensory, so audio, visual, smell. You can do like a pinprick, heat or cold sensation, what they can and can't feel. And this is beyond this class, but all of these are actually picked up by different types of sensory nerves. So the sensory nerves that are responsible for feeling a pinprick are actually different than the ones that detect heat and temperature changes. So maybe somebody with a CNS problem can't feel when you try to use like a pin on their foot or something. Maybe they can't feel that, but maybe they can tell the difference when you put a cold pack on their foot or a heat pack on their foot, because it's picked up by different sensory information. You look at mental function, simple questions, other cognitive functions, and different tests and measures that you could use. Cerebral spinal fluid or spinal tap. This will give you an idea of the actual content of the spinal fluid around the what's going on in the brain or spinal cord. So you're looking for certain pathogens, leukocyte numbers, potentially RBCs and neoplastic cells. So if they're potentially cancer. And then measurement of intracranial pressure, which give you an idea of that. If there's excessive pressure going on, maybe there's too much spinal fluid or something causing disturbances, and that could be from trauma. It could be from a potentially a concussion. So you'll also do an X-ray of the skull and vertebral column. You can do a myelogram, which is looking at the spinal cord, an angiogram looking at blood vessels, and that's what they're showing here, using dye to get a idea of what is going on with the blood vessels. Are there any occlusions or signs of a stroke or signs of ischemia to certain parts of the brain? You can also do an EEG, or what they call an electroencephalopathy, looking at the brain activity. So this is looking at electrical activity of the brain. If there are brain waves going on, they'll do this commonly. And if someone's maybe on life support, and they do an EEG, it could be showing that there's not brain activity going on. So being an indication that someone is then brain dead. Also, CT or MRI are useful for diagnosing what the problem is. Okay, so some infectious diseases. We have encephalitis, which encephalopathy is a very common problem, particularly with those who are aging. Inflammation of the brain tissue caused by viruses. Yeah, so inflammation of the brain tissue caused by bacteria or a virus. Symptoms would be headache, elevated temperature, stiff neck and back, lethargy. Very common, or probably one of the more complained about ones, or that you would see easily, would be this mental confusion, and then could lead to a coma. Treatment is supportive. Using antiviral medication may be effective. And then you have this, the difference between meningitis versus encephalitis is that you have this covering around your brain and around your spinal cord, referred to as meninges. If the meninges are the ones that are inflamed due to bacteria or viral infection, it's meningitis. If it's the brain itself, then it's encephalitis. Meningitis, inflammation of those meninges or coverings of the brain and spinal cord. Causes could be really any sort of pathogen. And there are several layers to these meninges. There's actually 3 different layers to it. Symptoms, you would look at high fever, severe headaches, photophobia, stiffness and resistance in the neck, or what they call nuchal rigidity. Nuchal just means neck. Drowsiness, stupor, seizures, and coma. Diagnosis, you do lumbar puncture to find causative agent. Whether it was, that would tell you which one of these causes it was. Treatment, antibiotics for bacterial infection, antipyretics or to lower the fever, anticonvulsants, quiet and dark environment. Poliomyelitis was a very common and kind of a very lifelong problem, and very infectious. It's not really, you'll see a lot of people now with what they call post-polio syndrome, which is kind of a reemergence of the disease later in life, or of the impairment later in life. This is something that we're not going to see much of anymore after, basically after the passing of a few generations, because of the effectiveness of eliminating this virus, but it's still something that you may come across. So it's a viral infection affecting the brain and spinal cord. Cause, virus spread by the oropharyngeal secretions and infected feces. Almost eliminated by the vaccine in the United States, though you'll have some cases pop up here and there, but it's not likely that you're going to see that. You may see people with post-polio syndrome still. Symptoms, you'll see muscle weakness, neck stiffness, nausea and vomiting, muscles atrophy, and possibly paralyzation. Diagnosis would be a virus culture from the throat, feces, and or spinal fluid. Supportive treatment, so analgesics, bed rest during acute phase, long-term physical therapy and braces may be needed. If there's respiratory involvement, mechanical ventilation may be needed. So that would be a more extreme case, very progressed pathology. Tetanus, highly fatal infection of the nerve tissue. This is another one that we don't in this country we don't typically see anymore because of the effectiveness of vaccinations. But this is a picture. I don't remember the time frame of what this picture is, but would be a picture of someone who had tetany, who was infected with this bacterial infection, several centuries ago. And you can see the extreme locking up of his body, that his body is so locked up that he's not putting himself in this position. His body is stuck in this position. You see, it's extremely painful, um, very fatal. A first symptom would be jaw stiffness, and then commonly called lockjaw. So if you ever heard that term before, this is what it's referring to. Rabies, an often fatal encephalomyelitis caused by a virus, primarily affects animals, dogs, cats, raccoons, and squirrels. Transmitted to humans through bite or of the infected animal. Symptoms will be fever, pain, paralysis, convulsions, rage, spasms, and paralysis of muscles for swallowing, throat spasms leading to hydrophobia, or just not wanting to swallow fluid, and then leading to inability to swallow, drooling of frothy saliva. The treatment would be immediate washing of area with soap and water, anti-rabies injections before onset of symptoms. And so if someone, typically there's kind of a latency period, and there's no cure upon onset of symptoms. But if someone is bitten by maybe a dog or something that is infected with rabies, if they get the treatment before the onset of symptoms, then they can uh, alleviate a lot of the problems that are associated with it. So you, it's, getting the rabies vaccine is not a typical thing someone does unless they go to, typically it's done if you go to like a foreign country where they may have areas where there's a large amount of monkeys or something that have it that could potentially bite. Then you may get the vaccine before then, which would then alleviate a lot of the problems. Shingles, this is the viral disease caused by the herpes zoster or chickenpox virus. And so you can see here it's done. Typically what you see is this kind of this dermatomal path of this nerve distribution. So the herpes zoster virus, after someone has it, it lodges in the sensory nerves of people's nerves, and then could then become irritated. And so what it'll cause is this painful red rash with these small fluid-filled vesicles along that sensory nerve pathway. Typically, symptoms last 10 days to several weeks. Diagnosis based on the appearance of the lesions and viral cultural tests. This is going to be one of those things likely in the future. Most people won't end up having shingles anymore because, when I was a kid, what you would typically do is you would just, if you had a kid who had chickenpox, you'd put all the kids in a room and they'd all get chickenpox. And then that was the way to kind of build up this immune system. You do it long enough, but now they have the vaccine that's no longer necessary to do that. And so it stops people from having the viral infection to begin with. There's no cure. Treatment is for symptomatic relief. Antivirals, analgesics, antipyretics, or antipuretics. Vaccine recommended by CDC for adults over the age of 60. A CVA, or a vascular disorder, this is also a stroke. It's due to poor blood supply to the brain. Most of the time, about 80 to 85% of the time, this has to do with an ischemic stroke. Means it's cut off of blood supply or low oxygen. The other 15 to 20% is what they would call a hemorrhagic stroke. So both a thrombus or more likely an embolus is a clot. These two would lead to an ischemic stroke, and then this cerebral hemorrhage would be bleeding in the brain, which would also cause a decrease in the blood supply. A thrombus would be a blood clot that formed in the brain itself, and then an embolism would be the blood clot formed somewhere else and then is traveling in the blood. That's more likely what it is. There are times where a thrombus could form, but most likely it'd be an embolus. Symptoms, numerous symptoms depending on the area of the brain affected and the severity of the CVA. So I've worked with a lot of patients with strokes, and every one of them have behavioral, physical impairment, cognitive impairment, have all been different in the way they present. And so it really just depends on what part of the brain is hurt and how much. And so there's some similarities, but they're all different at the same time. Sudden loss of consciousness, confusion, poor coordination, dysphagia, hemiparesis are common signs that you'll also see. Diagnosis would be a physical exam, EEG, CT scan, or MRI. Definitely would be an MRI. So if someone is suspected to have a stroke, you would need to know, the doctor would need to know, is it from a embolism, like an ischemic stroke, or is it a hemorrhagic stroke? Because with a blood clot, you would want to give them some sort of blood thinner to break up the clot to increase blood flow to the area. If you gave them a blood thinner and they were having a bleeding stroke, a hemorrhagic stroke, you would then further the problem and would kill them. So the treatment for one would actually be damaging for the other. So you would need imaging to find out what type of stroke it is occurring. Treatment, anticoagulant, if it's due to embolism or thrombus, hypertensive medication, and then would need extensive rehabilitation program following the stroke. And it really just depends on what their abilities are. Once you have a damaged, completely, let's say a certain area of the brain that is actually, the brain cells are dead, we're unable to recover them. But there's sort of an area around that is only partially damaged. That area, depending on how someone recovers and the rehab that they get immediately following the stroke, they can see a lot of long-term benefits to it, and they could potentially recover part of that area. Risk factors include smoking, high-fat diet, obesity, lack of exercise, and surgical prevention and treatment, carotid endarterectomy. So if you need to take that out. Transient ischemic attacks. So this is kind of what they would call like a mini stroke. So not quite to the point of having a full-blown stroke, but you will see some symptoms that are similar to a stroke. Due to insufficient blood supply to brain, this could be like a vascular change. So maybe you have like a blood cell constriction, which blocks off some of the flow to the brain in a certain area. Symptoms last a few minutes to 1 hour. So not to the point, typically we're going to see brain death or brain cell death. But you will see stroke-like symptoms during that time. Symptoms could be weakness of arm and or leg, dizziness, slurred speech, mild loss of consciousness. A diagnosis by an angiogram, so they can actually visualize the area that the transient ischemic attack is occurring, and the treatment would be surgery to improve blood flow, or so either almost like basically expanding the blood vessel, allowing for blood to go there. They could potentially use some sort of a vessel dilator as well. So functional disorders, so degenerative disc disease, headaches, epilepsy, Bell's palsy, and Parkinson's disease, or other types of things that you will see with neurological problems. Even though degenerative disc disease is an issue with the spine and the disc in the spinal column, any kind of problem with the spinal column is also going to be a problem with the spinal cord. So these are some other problems and issues that you will see. So degenerative disc disease, or this wearing away of the intervertebral disc. So if you You can see kind of this normal healthy disc size. If you have a degenerative disc, it actually starts to lose its size. Part of the reason why you see with people who are aging, they are shorter now. Well, it's because their intervertebral disc are actually starting to compress down, and it could get to the point if it's so compressed, it actually becomes a degeneration. It allows for the vertebrae to bump or rub against each other. So you can see that compressing. You see, as this top vertebrae compresses down now on this bottom one, you'll actually start to impinge nerves as they come out of the spinal cord. Symptoms could be difficulty walking or radiating pain in the back and or both legs. So if people have back pain, a lot of times I'll screen them and start to see where does the radiating pain go down? Does it go down into the thigh or down to the foot? Do they have feelings of numbness or tingling, anything like that? Treatment would be rest, back and legs, back brace, analgesics, anti-inflammatories, exercise to ease the pain, and then potentially surgery. They may need to go in and do potentially a fusion or something to try to reduce the degeneration of that disc. Headaches, one of the most common disorders in humans, usually a symptom of another disease rather than a disorder in and of itself. Typically, it's something else is going on, but we typically just kind of cover it up with pain medication. Disorders that typically have headaches as a symptom include sinusitis, encephalitis, and anemia. So you see several disorders which includes headache as one of the symptoms, and this list is actually a lot bigger than this if you included all of the pathologies. That headache would be one of the symptoms. Caused by two mechanisms, either tension on facial, neck, and or scapular muscles, or vascular changes in arterial size of vessels inside the head, which is kind of probably the more common one. I guess I don't know that for sure, but probably the more common type would be this. Contributing factors would be stress, potentially toxic fumes or noise, lack of sleep, alcohol consumption. You could also have be dehydrated. Maybe several things going on that lead to headaches. Some types, you can see a tension headache. You also have a cluster headache. The symptoms kind of cluster together in certain brain locations or certain areas of the head. You could also have it following a lumbar puncture, and also migraines. A treatment would be some lifestyle changes, so you can try to improve diet, sleep, exercise, use of painkillers, bed rest, massage, other things to help you relax. If it's, potentially you can try to alleviate at least the severity of the symptoms of the headaches. Okay, next, epilepsy. It's a chronic disease of the brain where you have intermittent episodes of abnormal electrical activity in the brain. Symptoms, seizure and convulsions. So common types of seizures. You have a petit mal, which is a slight change in consciousness. Petit mal, you can think of this as being, I think if you think of a person who's petite, it's a small amount of the brain that is affected, or a smaller amount of the brain. If you have a grand mal seizure, it's the entirety of the brain itself having a seizure or convulsion. Status epilepticus, continued convulsion seizure. Diagnosis would be by EEG, CT scan, cerebral angiogram, and blood test. And then treatment, you'd use anticonvulsive medications, close monitoring, and adjusting of medication if needed, if the medication itself was potentially causing it. Bell's palsy, what this is that it's a paralysis of the seventh cranial nerve, or the seventh cranial nerve, also known as the facial nerve, leading to this unilateral paralysis. And what you'll see is So you have one side here is active and the muscle is working, and you have the other side here where there's paralysis. So if you ever see a picture of someone who's like smiling and has Bell's palsy, sometimes if you look at it, if they're smiling, it almost look like the healthy side will look um, like, oh, it's kind of, that almost looks like it's the dysfunctional side, but it's actually the other side. So you'll see kind of a pulling back here because they have muscle function on this side. So if she were to smile, she'd have muscle function where her lip could pull back and expose her teeth, but on this side, there would be a lack of movement. Usually affects individuals 20 to 60 years of age. Symptoms: drooping of or weakness of eye and mouth, inability to close the affected eye, drooling of saliva, unable to whistle or smile, at least on that side, unable to smile, distorted facial appearance, diagnosis by history and symptoms. Treatments would just be analgesics because there's pain associated with this, and then anti-inflammatories. And then Parkinson's disease. This is a slow progressive brain degeneration. It's part of the brain called you don't need to know this, but the substantia nigra, which starts to deteriorate within the brainstem. But cause is mostly unknown. That's just one of the things that is kind of seen is that substantia nigra may be related to decrease in dopamine. And so people who have Parkinson's disease typically treat it with some sort of dopamine drug, and it's seen to help at least slow the progression of the disease itself. So the most common symptoms that you'll see with someone with Parkinson's is rigidity and then immobility of hand and extremities. Very slow speech pattern. Also, you'll hear their speech will get a lot more quiet. Pill rolling motion of fingers, almost like you're kind of like rolling up a ball of clay or something in your hand, in your fingers. Expressionless facial appearance, abnormal bent forward posture, short, and this one right here I see a lot too, is short, fast running steps with shuffling appearance, almost kind of like you almost have like shoes on or like slippers on that are too big, and you're trying to keep them on. It's very short, kind of a almost like a tapping appearance to their steps, and it's what they would call a shuffling gait. Symptomatic treatment, so dopamine replacement, and then physical and psychological therapy. Dementias be loss of mental ability due to loss of neurons, brain cell and or function. So there's a few different types of dementia. So senile or old age dementia. Many of us have heard of Alzheimer's disease. This is the most common type of senile dementia. Senile and Alzheimer's disease are often used synonymously, but they are not quite the same in that dementia is a broad term used, it's almost similar to autism, in that autism is a spectrum of behavioral and social problems that a person will have, and it's the same thing with dementia, in that there are different types of dementia. Most of the time a lot of times related to age, but sometimes can be related to medications or following head trauma or from substance abuse. If someone has a long history of using certain drugs, it can lead to dementia even though they're pretty young. I've seen someone as young as 35 have dementia because of substance used. So looking a little bit deeper into the senility and Alzheimer's disease, Usually affects individuals age 70 and older. Early symptoms, short-term memory loss, inability to concentrate, and slight changes in personality. As the disease progresses, you'll start seeing diminished communication skills, meaningless words, inability to form sentences, increased forgetfulness, irritability, and agitation. So you can see it starts sort of simple and then kind of progresses to a significant amount. Positive only by autopsy with diagnosis, but there's enough behavioral things with it that you and there's a ability to diagnose it when someone is living. Initially, diagnosis may be made by ruling out other brain diseases. So kind of ruling it against other pathologies it could be. Treatment supportive, no known cure, focused on safety, maintaining nutrition, hydration, personal hygiene, emotional support for family and caregivers. Be very will be very difficult for the family and caregivers trying to take care of somebody who has a more progressed Alzheimer's disease or any type of dementia. Vascular atrophy and death of brain cells due to decreased blood flow. Um, can't really see it too well, but you can see here on this picture, this atherosclerotic plaque can cause decreased blood flow, common with aging. So you can see this buildup in blood flow, and over time, this decreased blood flow that is getting through to certain parts of the brain will then cause the death and the atrophy of of those brain cells. Symptoms: changes in memory, personality, and judgment. See some of the other ones. Diagnosis: history and physical blood flow testing. And you can see here that the plaque can be removed through surgery, through this carotid endarterectomy, and so that would be effective. But if it's caught early enough, it depends on when they catch it, and depending on how much damage has already been done. Head trauma, death of brain cells due to head trauma. Um, Symptoms: decrease in mental intellect and cognitive function, loss of ability to reason, remember, or show appropriate emotions, and changes in personality. And this could be from a vehicular accident or sports, or it just depends on it could be anything, any kind of direct trauma to the head. Treatment: looking at correcting damage, if possible. Therapy and rehab is often easy to prevent with proper use of protective equipment. So they've that's kind of been the focus of a lot of sports, is trying to prevent head trauma to begin with. Substance induced, brain cell death from drug toxicity and toxins. Toxic substances includes really any type of either drug, or they've even seen with certain insecticides and mercury, which you don't really find nowadays, people just playing with it. But I think I remember even as a kid in the science class, we were playing with some mercury, but they found that it wasn't very good. Symptoms: mental impairment, decreased cognitive ability. Insomnia is the most common form of sleep disorder, inability to fall or stay asleep. And so it would be not just it would be a chronic thing that's going on for days and weeks and into months, and then eventually into years, that somebody would be struggling with this. Um, Causes could be multifactorial, could be any number of things. And so the treatment will be depending on what the cause is. Sleep apnea. This is another sleep disorder characterized by periods of breathlessness. So there will actually be a cessation of breathing at certain times or multiple times when someone is sleeping. More common in men. Some causes would be obesity, hypertension, airway obstruction, alcohol ingestion, cigarette smoking. And you can see some of the symptoms. Diagnosis would be monitoring affected individual during sleep for apnea. and low blood oxygen levels. So they have sleep apnea tests that people can do where they test for this while they're sleeping, and then treatment would be depending on the cause of it. Mostly preventable by maintaining healthy weight, avoiding alcohol, not smoking, and avoiding environmental smoke. Okay, now looking at brain tumors, classified either as a primary or a secondary. Primary tumors are called brain tumors. Secondary tumors are named after the organ of origin, so if it's metastasized from somewhere else, and the cause being unknown. Symptoms would include any of the ones listed here. And then, like many of these, but really with any kind of neurological thing, you're going to look at imaging. So you're going to look at using X-ray, CT, MRI, potentially a biopsy or other blood work, and then surgery, radiation, and chemo being part of the treatment. Okay, so trauma, you can think of concussions or contusions. Really, what the um, if you, and this is looking directly as like a contusion to the head, so like a bruising of the brain. A concussion would be like a less serious than a contusion of the brain itself, but um, there's kind of like a broad term used for all types of concussions being just a concussion. So it could be to the point where the actual brain itself has been bruised, or there's contusion, which would be a more serious form of a concussion. Cause would be a blow by an object or fall or other trauma to the head. What you'll see is disruption in normal electrical activity in the brain, potentially unconsciousness lasting a few seconds to hours. Obviously, the longer that someone would be unconscious, the more serious that the trauma was. Headache, blurred vision, and then possibly irritability and drop of knees and begin vomiting. So if it's serious enough, you'll start seeing vomiting. Contusions can lead to a hematoma. So you can see here, and sometimes there's, it may not be, let's say right here, what this is showing is that you have, let's say this person's head, I guess it's looking like it's hit like a glass window. Let's say there's a vehicular accident and their head comes forward and hits and breaks through the glass. The initial impact section here is called the coop lesion or coop contusion. Well, what happens is that your brain is actually sitting, it doesn't actually directly touch the walls itself. It's a little bit smaller than the cranium itself. And it's actually sitting in this fluid-filled area of that's cerebral spinal fluid. And so what will happen is that the brain will come forward and hit against the front part of the cranium. And then when the head goes back, and then there's this rebound effect, is what they call a contra coop contusion. And so you end up having an impact here on the front, and then the brain goes back on the when the head goes back, and the brain itself hits back against the posterior side. So, like from a rehabilitation standpoint, if somebody hits the front of their head hard enough, I could also be seeing. So here, the front part here is the frontal lobe, which is involved with like decision making and executive thinking and function. And then let's say back here, you have the occipital lobe. So it's potentially you could have some visual disturbances as well. So depending on where they hit and where the coop and contracoop area is, you could have then areas of damage in multiple locations leading to multiple symptoms that may not be related to the initial impact. Diagnosis would be history of injury, a neurological examination, and then other imaging techniques. Treatment initially, especially if it was very severe, would be bed rest and direct observation. Individuals should be checked every 2 to 4 hours. Monitoring of changes in consciousness, eye pupil size, mood, and behavior. Analgesics. Typically, with analgesics, you're going to use something like Tylenol and not ibuprofen, as ibuprofen or aspirin is an NSAID, or what they would call a blood thinner. So if there was a contusion and there was bleeding in the brain, you're not going to want to give them something that would increase the bleeding in the brain. So analgesics would typically be a non-NSAID or something like Tylenol, potentially a stimulant to keep them awake. And as you can see, sedatives should not be given, as that could be very dangerous, and they give them a sedative and they may not wake up. Medications may mask symptoms and make assessment difficult, so could mask some of the problems initially, but typically, if the damage is enough, you kind of get an idea of what their impairments are anyway. Skull fracture, a break in a cranial or skull bone. Greatest danger is brain tissue damage from bony fragments. So if there's like a splintering or almost like an impact hard enough to where you start getting fracture of the bone, and then it starts hitting or damaging the brain itself. Potential of cutting the brain, severing vessels, causing hematoma. Brain damage may be temporary or permanent, depending on the amount of time of loss of blood supply to the area. A variety of symptoms depending on the location of the fracture. Fracture near the base of the skull may cause impaired breathing. The reason why that is because, let's see if we have here at the base of the skull, right here, you have your brainstem. Your functional ability for your brainstem has a lot of functions, but one of its main, this area is actually important for just keeping our base functions, keeping us alive. And so higher areas like this are involved with like thinking and moving and making us who we are, and all these things. The brain is obviously extremely complex, but just the base functions of just simple cardio, cardiac, keeping the heart going, keeping our breathing going, actually comes from this region. So if you had a fracture in the skull here that impacted any part of the brainstem, it could be very dangerous. And that's actually why somebody who has a stroke in this region of the brainstem, if they do survive, the initially would be significantly impaired, almost to the point of there wouldn't be much function to them that they could get back. They would basically would be almost either in a vegetative state or in an extremely impaired state for the rest of their life. So symptoms could be, kind of just any damage of the brain could just be depending on what part of the brain is damaged. Treatment, depending on the type and position of the fracture, craniotomy may be necessary to relieve intracranial pressure. So if there's extreme swelling of the brain, there is the potential a surgeon may have to go in and remove part of the brain, not part of the brain, the skull, and allow for the intracranial pressure to not be so much that there's increased damage. And then protective headgear may be necessary until the fracture is healed. You also have epidural and subdural hematoma. So this is basically blood pooling in certain areas of the meninges. An epidural hematoma is a collection of blood between the bony skull and the dura mater, which that is the outside layer that is immediately along the inside. So if we were looking here, so let's say this right here is the skull itself. Immediately under it, you have the dura mater. So the hematoma would be in between that dura mater and the bone itself. Back. Um, the subdural hematoma is a collection of blood between the dura mater and the arachnoid mater. So arachnoid mater would kind of be in this area between the brain uh, and the dura mater, and then overlying the dura mater is another thin layer called the pia mater, and so that subdermal hematoma would be between those two, and that one subdermal hematoma is more serious. Um, the subdural hematoma occurs twice as often as an epidural. The diagnosis would be through imaging, and then treatment goal is to decrease the intracranial pressure. Pressure can be relieved by either special craniotomy, a craniotomy called a burr hole. So it's basically the, the surgeon will basically drill like a hole in their skull, and intracranial pressure could be released that way. It would just be like the hole would be kind of almost like the size of a nail or a screw, and then potentially electrical cauterization. Okay, this going a little bit deeper into epidural hematoma. You see here where the collection of blood is between that the bony skull and the that dura mater. Usually the result of a fight or accident, blood vessels rupture, and hemorrhage or um, seep blood, usually rapidly over a period of hours. So it's kind of these outer blood vessels maybe get damaged or something, and then this hematoma forms. Usually occurs within hours, headache, dilated pupils, nausea, vomiting, dizziness, and as the hematoma grows, potentially loss of consciousness and increased intracranial pressure. It just depends on the amount of bleeding that is occurring and if it's able to be stopped. And then up here, you can see a subdural hematoma where the dura is still attached to the skull. Here on the epidural, the dura starts to pull away from the skull. Uh, Subdural hematoma usually a result of head hitting stationary object, as in seen with falls from a head hits the floor. Blood vessels rupture and seep blood slowly, usually over a period of days. Symptoms being hemiparesis, nausea, dizziness, convulsions, loss of consciousness. Okay, spinal cord injury um, usually results when bony spinal column is injured or fractured. You could also see it though you could see spinal cord injuries or spinal cord injuries from gunshot wounds, um, vehicular accidents, which would be the result of this bony spine column injuring the spine itself. The cord can be injured at any level. The neck area is most vulnerable, and really, if someone has a spinal cord injury, you're hoping if they do have one, the lower the better. If it's up really high, let's say it's like at this. Let's see if we can see it right here. Let's say it's up here at like the C2 or C3 level. They have a spinal cord injury. Let's say they have a fall, or I believe Christopher Reeves, the man who played Superman, he had a accident. He's passed away now, but he had an accident, and I think it was a horse accident, and he hurt his spine, and he hurt it around this level. I don't remember which level he was, but I think he was a C2 or C3. When someone is this high of a spinal cord injury, they only have function of they do have the ability to shrug their shoulders, and that's because of the ability to shrug your shoulders or your traps. It actually comes from one of your spinal or sorry, it's one of your cranial nerves, but they're unable to breathe on their own. And so, and this is just kind of for your information, but the phrenic nerve, which innervates your diaphragm so you can breathe, comes from C3, 4, and 5. And so, if someone is a C5 injury or lower, they'll at least have the ability to breathe on their own. Maybe not super well if they're a C5, but they can breathe on their own. And so you get more and more function in your arms the further you go down. And if you get down into the thoracic spine, let's say it happens here and it happens below this C7, C8 level, somebody can have full use of their arms, but they, wouldn't have any control or very poor control of their trunk and no control of their legs. So really the further down the spinal cord, the better as far as people's functional ability. Cause be automobile accidents was the leading cause, but it could also be gunshot or knife wounds, falls, and sports injuries. Okay, so going here, symptoms, varying degrees of injury. And you see here, C1 to C3 is usually fatal. The only way that someone who has a C1 to C3 injury it isn't fatal is they're put on ventilation because they're unable to actually breathe on their own. And you can see here, you may have probably heard the term quadriplegia and paraplegia. If someone, and now all spinal cord injuries aren't the same. And you don't really need to know much about the classification right now. But let's say somebody injures their spinal cord and it's up here in the cervical region. These nerves right here are going to go to your arm. And let's just say they didn't hurt it completely, so they have some movement of their arm. Well, if they have any damage to this area at all, they're referred to, even though they may be able to move their arm some, or they have some ability, they're still referred to as a quadriplegic. You don't have to be completely paralyzed to be a quadriplegic. You just have to be in a cervical injury or higher, because if you have an injury up here, that means that the arm's going to be affected as well as everything below it. If they're injury to a thoracic injury, they're referred to as a paraplegic. So then they will have if they're thoracic spinal cord 1 or below, they'll have full use of their arms, but they'll have either difficulty, depending on where it is, with stabilizing their trunk and then their legs. If they just have a lumbar injury, it'll be just their legs and their trunk, and arms will be fine, and so on. So really, the lower, the better. Okay, so looking at more here, so quadriplegia, loss of movement and feeling in trunk and all four extremities. And like I said, it's not a complete loss all the time. It's not always, they have no movement. They could have some movement. But it would be impacted in the arms and legs. Loss of bowel, bladder, and sexual function. If severe, respiratory ventilation would need to occur. Paraplegia, loss of movement, and even this, there are some things that can be done. This isn't like a complete. It's not like they couldn't. There just have to be some things that would have to change, or some things they would have to do in order to engage in sexual activity. Paraplegia would be loss of movement and feeling in the trunk and both legs. Loss of bowel, bladder, and then again, same thing. There would be a loss, but it still could be. It may not be a complete spinal cord injury, so they could still have some function. Okay, diagnosis would be through neurological exam as well as imaging. Emergency treatment necessary. If there's suspected spinal cord injury, obviously do not move the individual unless surroundings are unsafe. Maintain position of spine with special collars and backboards. You've probably seen it with any kind of neck injury in a sport. They take precautions as to not move the spine at all. Treatment will be realignment and stabilization of the bony spinal column, decompression or release of pressure on the spinal cord, and then prevent further injury. Okay, another rare disease, but one that we probably most people have heard about now. If you remember, a few years ago they had the ice bucket challenge. That was for a disease called amyotrophic lateral sclerosis, also known as Lou Gehrig's disease. And Lou Gehrig was a famous baseball player that played for the Yankees who died of this disorder. What it is the destruction disease of motor neurons. And so what ends up happening is that these people have the inability over time to move their limbs and appendages. And then it starts getting to the point where the motor neurons to their diaphragm and their breathing muscles start to go as well. So eventually it's a disorder that when someone's diagnosed with it, it is 100% fatal. It there's It's really just about supportive treatment and just kind of preparing them over time with like equipment and things that they'll need until unfortunately they will pass away from it. Guillain-Barré syndrome. This is an acute progressive disease affecting spinal nerves. Uh, what happens is there's typically some sort of infection that the person has, um, and then begins 10 to 21 days after febrile illness. So they have some sort of infection, and then it'll start affecting their spinal nerves in a certain distribution. Early symptoms will be nausea, fever, and malaise. And then within 24 to 72 hours, paresthesia, muscle weakness, and paralysis usually begin. This is a disease that, if caught early enough, typically is not fatal, but can be fatal. It's a very severe symptoms and paralysis and weakness. And I know there's a pretty unique video that you can probably find on YouTube, or I've seen on YouTube once, that of this woman who was diagnosed with Guillain-Barré syndrome, and it took her nearly a year of rehab to get back to where she was. Symptoms may progress for several days to weeks. Once progression ceases, recovery then begins at that point. Supportive treatment, recovery usually complete, though there could be some lasting effects, and it really just depends on how early it's caught. If it's caught early enough, it's not as bad, but there will still be significant problems. But it can be fatal. Huntington's chorea is an inherited disease and autosomal somal dominant disease, so you have to inherit from both of your parents. Appears during middle age. It's a progressive, degenerative disease of the brain. Leads to mental deterioration. Symptoms be loss of muscle control and chorea. Chorea is kind of this. It's this kind of worm-like, slow move, almost like twisting movement, um, like these involuntary type irregular contractions that someone will have typically with their arms and legs. You'll see changes in personality, mood, behavior, loss of memory, and dementia. Similar to ALS in that there's no cure. It's just about supportive treatment until they pass. Multiple sclerosis cause is a demyelination, which is so the covering of our neurons, our nerve cells have this myelin around it. It's a demyelination of the CNS nerves. So occurring inside the brain itself. Allows signal to leak from nerve pathway. So over time, you think of like this covering as being this protective band, and if it starts to demyelinate, eventually the signal gets slower and slower, and then it just starts not getting there because this whole wiring has started to not work. Kind of like if you if you had like a phone charger or a laptop charger that started to strip off the covering on it or started to break, eventually it would start not working. Leads to poor or absent nerve transmission, symptoms, muscle weakness and lack of coordination, paresthesia, speech difficulty, loss of bladder function, visual disturbance, especially diplopia or double vision. Affects adults between ages 20 and 40. Um, Periods of remission exacerbation. This is, and there's different types of MS. So with some of the types, there is remission and exacerbation, meaning that there's times where it gets better for a little while and then it gets worse again. There's also a primary progressive in which there aren't periods of remission. It just is a slow decline in function. Um, with all types of function, with MS, if someone is diagnosed with MS, there will be a slow, it just depends on the type of MS they have. There, as they age, there will be a decline. They don't, there's not any cure. There's just kind of a trying to slow the amount of impairment over time as much as they can. So treatment would be physical therapy, muscle relaxants to maintain muscle tone and reduce spastic movement. And then some of the effects of aging, decreased nervous system activity in the brain and spinal cord, loss of short-term memory, loss of visual acuity and peripheral vision, and altered sleep patterns. So that wraps up our nervous system and endocrine presentation. If you have any questions, please let me know. And thank you.